Is there a limit to peak plasma concentrations of vitamin C that can be achieved through therapeutic dosing?
Well, when we talk about therapeutic dosing of vitamin C, we have to distinguish oral, which is helpful, from parenteral or IV, which is quite different. Orally, we should have a plasma ascorbate level of somewhere between 5 and 10 milligrams per deciliter, whereas most people are below 1. And that may not seem like a big difference, but in biology, it's a night and day big deal difference. So orally, using the C-cleanse and daily consumption of fully buffered, fully reduced ascorbates, such as Perc-Potent C-Guard, you can get into the healthy person's range for ascorbate, which means in the plasma and the blood, between 5 and 10. With regard to parenteral or IV ascorbate, somebody's moving and not muted, and if you're moving, please mute. I'm going to start the answer again if that's okay. The question about levels of ascorbate in the body makes a big distinction between oral uptake and parenteral or IV uptake. If we start with oral uptake, if you do the C-cleanse and you take the amount daily recommended based on the C-cleanse, you will go into the healthy person's range for ascorbate in the blood, in the plasma, and a healthy plasma ascorbate is between 5 and 10 milligrams per deciliter. Average Americans, less than 1, which means chronic scurvy. Now, most of us have heard about scurvy. Sailors deprived of vitamin C and citrus fruits would have gum problems, their teeth would fall out, their infrastructure, their collagen and elastin would begin to fray. You wouldn't be repairing the body. You cannot repair the body without adequate ascorbate. That's the headline. They were called limeys at a time because some British physician noticed that if you just had lemons or limes on the ship and fed them to the sailors, they didn't have such aggressive scurvy. But Albert Szent-Györgyi, the man who isolated vitamin C from Hungarian paprika for decades, pointed out that chronic subacute scurvy is endemic. This means it's beyond epidemic. It's very common. If you think that common is normal, you probably won't take supplements. If you think normal means something other than a statistical term, you've been misled in regard to that use of the word normal. Because in the laboratory, we talk about normal ranges, usual ranges, which means what we find usually. In contrast, Szent-Györgyi and more recently Beutner and others have pointed out that ascorbate has a unique function in the body. It sets the oxidation reduction potential. It does many other beneficial things. It helps us not be harmed by the oxidative burdens and toxins that we are exposed to in the 21st century. And so sometimes you do need parenteral or IV ascorbate. And over the decades, and I learned from Stan Dudrick, the man who introduced hyperalimentation to medicine. I'm not as young as I seem. And what he taught was you would give amino acids, you would give energy from glucose, and you could reduce mortality and morbidity. You could sometimes save lives with hyperalimentation, feeding by vein. Sometimes you add some healthy fat to that. But for decades, folks like me have been saying you need a non-insulinogenic hexose. You need a non-insulin-stimulating sugar. And it turns out that we're one of the 3 species on the planet that cannot convert sugar, glucose, into vitamin C. It's a non-insulinogenic hexose. It doesn't raise your blood sugar. It is helpful. It donates electrons and protects. It's the maternal antioxidant that sacrifices herself that all others can be recycled, enhanced, and preserved. And with regard to parenteral ascorbate, You want a peak level of 50 to 80 milligrams per deciliter. And very importantly, you want to measure just before the next infusion, what's called the trough level. That is, how low does the level go before the next infusion? And you want to stay above 10. And my recommendation is 10 to 15 milligrams per deciliter trough and 50 to 80 milligrams per deciliter peak. Now, there are some colleagues and researchers who, in artificial or laboratory or in vitro conditions, say that you get even more benefit if you go well above 100 milligrams per deciliter. My clinical observation is that 50 to 80 as the target for peak is safer and effective. And the trough level, just before the next infusion, should be 10 to 15 milligrams per deciliter. And now a tiny technical point: whichever arm you infuse into, you draw the specimens for peak and trough from the other or contralateral arm. So orally, you want to use the C-cleanse and take daily what you need to get into the healthy range of 5 to 10 milligrams per deciliter. And if you're doing hyperalimentation with non-insulinogenic hexoses like ascorbate, so you take the 50 grams of glucose bottle out and put it away, and you take generally 2 amps of 25-gram ascorbate equaling 50 grams. So you have the same tonicity, the same concentration as you would have had if you used the sugar. But now it turns out that when you have certain kinds of problems that sometimes people want to be fed by vein, this includes some cancer and other heart-related conditions. Here, if you use sugar, glucose, and raise the insulin, that ends up feeding the problem, not solving the problem. And you are more likely to get remission or improvement if you follow the non-insulinogenic hexose using ascorbate to achieve the 50 to 80 milligram per deciliter peak, and checking the trough level just before the infusion to make sure it's in the 10 to 15 milligram per deciliter range. So I hope that addresses the question. It's very different what your goals are with regard to oral daily intake for ambulatory people versus someone who has some very significant issue that requires parenteral feeding or IV feeding.